All right, so today we're going to be starting the GI series of the NCCPA blueprint for the Pance. This is 9% of the Pance, and I'm going to start with a couple of the more important topics for the GI section, and that's ulcerative colitis and Crohn's disease. So these are both two forms of inflammatory bowel disease. And before we go into each individual disease, I want to talk about some things that you're going to see in common with both of these as far as risks and different things like that. So as far as the race, the most common race you're going to see these in are Caucasian individuals. In particular, Ashkenazi Jews are at a higher risk for both ulcerative colitis and Crohn's. This is normally a younger person's disease, normally under the age of 30, anywhere from about 15 to 30 is the most common age of initial presentation. And then interesting thing to note is that smoking, while it increases your risk for Crohn's, it actually decreases the risk of flares in patients with ulcerative colitis. So the thought behind that is that the nicotine in these individuals who smoke actually suppress the immune system. And both of these are autoimmune processes. So suppressing the immune system leads to decreased inflammation in the colon, and also smoking increases mucus production in the colon, which has a protective barrier in patients with ulcerative colitis. So interesting that this is one of the few cases where smoking can actually be beneficial. Of course, in Crohn's disease, not the case. It does increase the risk. NSAIDs, oral contraceptives can all increase the risk both in ulcerative colitis and Crohn's disease, so that's important to know as well. And then some extraintestinal manifestations. So not everything that you see in these two diseases are going to always be presenting in the GI tract. You can actually see it outside of the GI tract as well. And one of the most important things is that you can actually have anterior uveitis, also known as iritis. So these patients aren't always presenting with symptoms like abdominal pain or diarrhea. They may actually have pain in the eyes. So it's important to know for real life situations and your boards as well, because they may actually ask you something like that. So the inflammation can occur anywhere. It's not limited to the GI tract. Another thing too, they may have deficiencies in B12 and iron. This is going to be more common in Crohn's disease because this is where these nutrients are absorbed in the small bowel where Crohn's disease can affect. So they may have some nutritional deficiencies, and they may have something called erythema nodosum, which is normally seen on the lower legs, and it's this painful red nodules, this inflammation on the lower legs. It's a form of, it's called paniculitis, which is actually an inflammation of subcutaneous fat. So these patients may come in, not sure what's going on, and they just have this pain and redness, these swollen areas on their lower legs, and it looks like this, and it's actually related to, it can be either ulcerative colitis or Crohn's disease, and normally in the lower legs you'll see these areas, so you need to remember that this can be caused from inflammatory bowel disease. Something else too is known as pyoderma gangrenosum, and this is a painful ulceration on the lower legs that can actually lead to necrosis. So this is something else that you need to be aware of, and this is one of the more tame pictures that I found. This actually can get pretty nasty, so you can actually have this necrotic tissue, and it eats away at the healthy tissue surrounding it. So that's something you may see more so in ulcerative colitis, but it can be seen in both. So those are some things that you can see in either one of these inflammatory bowel diseases. So now let's move into Crohn's disease and go over some things about that. So Crohn's disease was found, the disease itself was found by Bill Crohn, who was a gastroenterologist in 1932. The name obviously came from his last name. And it's an autoimmune inflammatory bowel disease with a relapsing remitting course. So you're going to have periods where it gets better and then periods of flares. The inflammation seen in the GI tract in patients with Crohn's disease is transmural, and this is important. There's going to be a few things that I'm going to point out that you need to know, because you have to differentiate Crohn's from ulcerative colitis in a vignette and in real life. In real life, of course, you're going to do imaging and labs and things like that, but more so for your boards and things like that, you need to be able to differentiate in the vignette. So you need to know that Crohn's disease is transmural. It's not limited to the submucosa. The mucosa goes all the way through the bowel, wherever it's affecting. So transmural, and it can affect any part of the GI tract. So anywhere from the mouth to the anus, Crohn's disease can occur. You can even get aphthous ulcers in the mouth all the way down to the rectum. This can affect anywhere along the GI tract. and ulcerative colitis is limited just to the large bowel again, so that's important for differentiating the two. And then the most common area to be affected is the terminal ileum. I have a terrible way for you to remember that. I don't know if it's going to help you or not, but it helped me and I never forgot it. So I don't know how old some of the people are watching these videos, but most people know there's a famous rapper named T.I., and T.I. is a rapper, and T.I. makes CDs, maybe not so much anymore, more like Spotify and things like that. But the way I remember that the Crohn's disease most commonly affects the terminal ileum is that T.I. makes CDs, and you can see here T.I. stands for terminal ileum, CD stands for Crohn's disease. So that's, maybe that works for you, maybe not. Anyways, moving on. So the rectum is often spared in Crohn's disease. It can be affected, but most of the time it's spared, and that's important to know because in ulcerative colitis, the rectum is always involved. So in Crohn's disease, it's often spared. So those are some important things to know for Crohn's disease, differentiating ways that you can differentiate. As far as how the patient's going to present, they're normally going to have right lower quadrant pain. And why are they having right lower quadrant pain? Well, if you remember what we just talked about with TI and the CDs, it's normally affecting the terminal ileum, which is in the right lower quadrant. So normally these patients will have pain in the right lower quadrant with Crohn's disease. They may also have diarrhea, usually non-bloody though. That's important to know because, again, another differentiating factor, ulcerative colitis is normally bloody diarrhea. So in Crohn's, it's normally non-bloody. Weight loss is something else that you may see in these patients, again, due to some of problems they're having in the bowel with absorption and things like that, and malabsorption. So that's another important thing to know. As far as diagnosing these patients, you're normally going to start with an upper GI series, and the upper GI series is going to show this tapered off or narrowed area of bowel. It's known as a string sign, and I'm going to show you in a picture in a second. You can see why. You have this normal bowel here. You can see above and below this area where this thin tapered off area, you have this normal patent bowel above and below where Crohn's disease is not affecting it. And then this area here, which is caused from all of the inflammation and scar tissue, you have this narrowed area where the barium can flow through. And it literally just looks like a string because it's so narrow, connecting the two areas. And that's known as a string sign. So that's something, it's one of those keywords that you should know. If you ever see that, you should think of Crohn's disease. So if you do a colonoscopy, you're going to see this discontinuous inflammation. So there's going to be areas of inflammation. You're going to do a colonoscopy. You're going to be looking at the bowel, and then you see this inflamed area, and then you'll go a few inches more, and then it'll be normal. And then you'll go back to this inflamed area, and then it'll go back to normal area of bowel. So these are known as skip lesions. So Crohn's disease, unlike ulcerative colitis, which is continuous inflammation, is discontinuous. So inflamed, normal, inflamed, normal. Those are known as skip lesions. And then the bowel in a patient with Crohn's disease is also known to have cobblestone appearance. I'm going to show you why, because in Crohn's disease, you have these inflamed areas that actually look, if you look at what cobblestone looks like, kind of similar to how cobblestone appears. So this is what the bowel is going to look like in a patient with Crohn's disease. So that's just another thing that you should know for that as well. So those are a couple of the tests that you can do. Some other things that you can do is a biopsy, and on a biopsy, again, you're going to see that transmural inflammation. Something else that you may see, which is important, is non-caseating granulomas, and this is something that's kind of a hallmark finding for Crohn's disease, and it can help distinguish Crohn's again from ulcerative colitis because you're only going to see this in Crohn's. And what this is, these granulomas are seen in a biopsy, you can only see it under a microscope, and they're a collection of macrophages that form in response to this chronic inflammation. So remember, if you see a granuloma on the biopsy, this is most likely Crohn's disease. Something else too, which is pathognomonic for Crohn's, is not seen in every case, but creeping fat. Again, not very common, but if you do see it, again, this is Crohn's all the way through. And it's something where the surrounding mesenteric fat actually is attached and attracted to the bowel. So 50% of the intestines in some cases can actually be covered in this mesenteric fat that migrates to these areas of inflammation. And they don't know exactly why this happens in Crohn's, but the theory is that it may be bringing this beneficial bacterial flora to the area, or they think that it may even be patching some of these areas where you may have fistulas and things like that that can form in Crohn's. It's another important thing to know as well, that you can have fistulas in Crohn's because you have this transmural inflammation that can burrow its way all the way through the bowel. So that's something else that you may see on the biopsy. As far as labs, there's something known as, I'm not even going to try to say this, but normally it's known as ASCA. That's a lab that you may see, which are just immune proteins that's more specific to Crohn's. So ASCA is something that you may see if you do labs. And then also, again, like we talked about before, is B12 and iron deficiencies. Is something that you may see in a patient with Crohn's, because remember that small bowel may be affected, and if you have all this inflammation and tissue that isn't functioning as well as it should, it's not going to absorb all of those nutrients, the B12 and iron. So you may have deficiencies in those areas. Moving on to treatment, there's really only a few things that you do for Crohn's, and if you think about it, it makes sense. So what is Crohn's? It's an autoimmune disease, and it's an inflammatory disease. So first of all, what do we treat for inflammation, or how do we treat inflammation? We use NSAIDs and we use steroids. So that's what you're going to use for Crohn's. And then what do you use in an autoimmune disease? Well, again, you can use steroids, and you can also use immunosuppressants. So that makes it easier when you actually think about it, and you can break it down. So if it's a mild disease, you're going to use something called 5-ASAs. And 5-ASAs, mesalamine is an example of that. 5-ASAs are actually, ASA stands for acetylsalicylic acid. And if you know what that is, that's just aspirin. So this is just a different form of aspirin. The 5 is just a different chain of that. So it's 5-acetylsalicylic acid. So literally, this is aspirin. But the difference between regular aspirin and this is they're formulated in a way to target the specific area. So these come in many different forms. Some are PO like mesalamine, some are suppositories, some are actually in a form of foam that you can have introduced into the bowel. And the oral ones have a coating, so they actually get absorbed into the small bowel and it's somewhat into the large bowel. And it all depends on where you're trying to target. So for instance, if you had inflammation up to the splenic flexure, on the left side, you could use an enema. Suppositories will normally target the rectal area. And then PO medications like mesalamine normally target the small bowel and the right side of the colon. So again, these are really just NSAIDs, but specifically targeted to certain areas of the GI tract. In more severe disease, you can use glucocorticoids. Sometimes even in mild disease, you can use this as well. But the 5-ASAs normally work pretty well in mild disease. In more severe refractory disease, you can start using immunosuppressants like methotrexate and your TNF agents like infliximab and those types of things you can use in severe and refractory disease. As far as surgery with Crohn's disease, it's going to be non-curative. You can't cure Crohn's disease because you'd have to take out the entire GI tract, which is impossible. So it's really only palliative, and you're going to use it in patients who are having really severe symptoms. Sometimes you can remove the damaged part of the bowel, but it will not cure it. Whereas in ulcerative colitis, you can actually remove the entire large bowel and cure ulcerative colitis. Crohn's disease, it's only palliative. So we went over a lot of things for Crohn's, and I have a way for you to remember some of the more important things. Most important things to remember for Crohn's are ways to differentiate between Crohn's and ulcerative colitis. So some of the important things about Crohn's are really 4 things, and I made a way for you to remember this. So Crohn's disease, the initials are CD, Crohn's disease, and there's 4 things that you should know about Crohn's disease to help differentiate, because all of these are going to be the opposite of ulcerative colitis. So Crohn's disease, CD, completely diverse. So it's any segment of the GI tract from the mouth to the anus, so it's completely diverse. Completely deep, because it's transmural. It goes all the way through the mucosal membrane, deep. Remember, different than ulcerative colitis, that's only superficial. Completely dry, normally non-bloody or dry stool. Again, ulcerative colitis is bloody stool. And then completely discontinuous, non-continuous inflammation. Remember those skip lesions. Ulcerative colitis is this continuous inflammation, whereas Crohn's disease is discontinuous. So those 4 different things, that's a good way to remember Crohn's disease. These are all ways to differentiate from ulcerative colitis. Completely diverse, any segment of the GI tract. Again, ulcerative colitis is only the large bowel. Completely deep, transmural, through all layers of the mucosal membrane. Ulcerative colitis, just superficial. Completely dry, non-bloody or dry stool. Ulcerative is bloody stool. And then completely discontinuous, non-continuous inflammation, skip lesions. Ulcerative colitis is continuous inflammation all the way through. Okay, let's move on to the last part, which is ulcerative colitis, and bring this home. So ulcerative colitis, this is also another autoimmune process, and it's an inflammatory bowel disease with inflammation of the colonic mucosa. It's going to be only affecting the mucosal and submucosal lining of the large intestine. Remember, we talked about Crohn's disease. It was transmural. This is only a superficial, only the mucosal and submucosal lining of the large intestine. So very important to differentiate. It's limited just to the colon, doesn't affect anywhere else. And then the rectum is always involved. Remember, Crohn's disease, rectum is usually spared. Ulcerative colitis, rectum is always involved. I have a simple way to remember both the fact that this is limited only to the colon and that the rectum's always involved. I know colitis itself basically means inflammation of the colon, so it's kind of easy to remember it's only the colon, but just in case you get confused on the exam or you're really nervous. So remember ulcerative colitis, just remember ulcer, and ulcer stands for usually limited to colon, especially rectum. So that helps you remember it's only in the colon, especially the rectum. The rectum is always involved. So this is going to be continuous inflammation, again, separating from Crohn's disease all the way through. There's no skipped areas. And then as far as the presentation, it's going to be a little bit different than Crohn's because now you're going to have bloody diarrhea instead of normally dry diarrhea in Crohn's. And again, remember, this isn't 100%. Nothing in medicine normally is. You can have bloody diarrhea in Crohn's disease, but it's not as common. And remember, on the boards, they're probably going to present it to you in the most common way. They're normally not going to try to trick you. So remember, ulcerative colitis is going to be bloody diarrhea. And the abdominal pain now, instead of the right lower quadrant, is more common on the left lower quadrant. That's the area that you're going to see it more commonly as far as the pain these patients are going to have. And then they may also have something called tenesmus, which is this feeling of incomplete bowel emptying. Even after they have a bowel movement, they're still going to feel like they have to move their bowels. And this is normally due to all of the inflammation they have in the bowel. They're going to have this continual feeling that they need to move their bowels or their bowels are full. So that's something that you should remember as well. And then in more severe cases, they may actually have toxic megacolon, which is possible in ulcerative colitis. So they may have signs of toxicity like fever, increased ESR, those inflammatory markers. Some complications that you can see in ulcerative colitis, these patients are more at risk for colon cancer. And if you think about it, the large bowel is continuously inflamed. So this inflammation can lead to colon cancer. So that's important to know for these patients. And then also primary sclerosing cholangitis. I don't know if you remember this, but this is an autoimmune disorder of the intrahepatic small bile ducts. And trust me, they ask you stuff like this. So it's important to know that if you see a patient with ulcerative colitis, they may also have primary sclerosing cholangitis. A lot of times these two go together, so remember that as well. These are a couple of the complications in addition to toxic megacolon, which I just talked about before. So yeah, toxic megacolon. As far as diagnosing these patients, there's a few different ways you can do it. If you do a flexible sigmoidoscopy, you're going to see that continuous ulceration. So it's not going to skip like it did in Crohn's, just continuous all the way through the large bowel. It's all going to be ulcerated and inflamed. A barium enema is going to show something called a lead pipe or stovepipe sign. I'm going to show you a picture of that, but this is a complete loss of the haustral markings through certain areas of the bowel. So if you look on the right side of the x-ray, it's going to be your left, the right side of the x-ray facing you there. You're going to see the haustra. You see these areas that kind of outpouch here, and you see these different like little divots that come in. That's the haustra of the bowel. So this side is not as affected. And then if you look on the left side of the x-ray, which is going to be your right facing the screen, you're going to see the straight area, no haustra. It's completely lost, and it's straight. So that's why they say it looks like a pipe, like a lead pipe, because a lead pipe is smooth. It doesn't have any indentations. So that's where the lead pipe or stove sign comes, stove pipe sign comes in. So you can see that there. This is a good picture to kind of show you, contrast the two differences. So that's what you see if you did a barium enema. As far as labs compared to Crohn's disease, where you saw ASCA, in this case, you're going to see something called PANCA. So don't think too hard about that. Just remember PANCA is more common in ulcerative colitis and ASCA is more common in Crohn's. And then as far as treatment, again, your 5 ASAs are going to be one of your first lines. But in this case, you're normally going to use the topical forms. As you know, some of the foams, the suppositories, because remember, again, this is only limited to the large bowel. So you can actually target these areas a little bit easier with some of the suppositories and enemas and things like that with the 5 ASAs. You can also use glucocorticoids in more severe cases. And then surgical resection can actually be curative. in severe and refractory cases. Again, you'd have to remove the entire large bowel. So this isn't ideal, but it can cure the disease. And it's also good in a patient that you feel is a high risk for colon cancer, to remove the entire large bowel to take away that risk of colon cancer, or for a patient who's just kind of refractory and not getting any better with other medications. So immunosuppressants do have a place in ulcerative colitis treatment, but they're not as common as in Crohn's. But in certain cases, you can use cyclosporine or infliximab, and really most of the time in real life, they're more used in an attempt to delay surgery rather than a first line treatment. Your 5-ASAs and your glucocorticoids are going to be used first, and your immunosuppressants more later down the line, but definitely not a first line treatment. So those are your treatment options for that. And that's really all that I feel like you need to know for ulcerative colitis. Those are the main things. And I just want to thank you again, everybody, for watching these videos. I also encourage you to check out my podcast.